Good morning. We are having a ward round scenario discussion, which will be on burn injury management. So we'll discuss and we'll have a in-depth discussion on the whole of burn management. So today, Professor Prashant Kumar Bhattacharya will be taking us through the scenario. Dr. Bhattacharya is Professor and Head of Surgery at Bankura Shobhilin Medical College. Okay, so starting the scenario. Yes, share the scenario. Dr. RM Jyoti will be presenting. She is a third year resident at MR Bangalore Hospital. Yes, she did.
Good morning, sir. 28
Good morning.
accident involved the fire. She presents to emergency 4 hours after the accident. How will you proceed?
Okay. Yes, very much. Okay. Dr. Bhattacharya, how she should start?
Okay. So this is a case of accidental burn, you said, no?
Yes,
Yeah.
sir.
Yeah. Whenever a patient comes to you with burns, what are the important things that you should ask the patient at the very beginning?
Sir, first I will start with the resuscitation of the patient, the primary survey.
Mm-hmm.
I will check her airway. Whether airway is patent or not, any carbonaceous metal is there, and I'll check for any breathing difficulties or any chest. I'll ask her and bilaterally, and see any constrictions are there in the, whether chest movements, and I'll start with the circulation. So I'll check her vitals and start with the resuscitation. And I will expose the patient completely and see for any disability is there. And
Okay. When you are continuing with your resuscitation, should you simultaneously ask a few things?
Yes, I'll ask
important.
I'll
Important things in the history, like.
I'll ask the patient how the patient got fired and
Yes.
at what time and
circumstances of the injury, that is very important.
And yes, sir.
You should also ask the family members whether the injury occurred in a closed room or whether she was evicted from that room immediately after the onset of the burn. Why is it important to know whether it occurred in a closed room or not?
If it is in closed room, there is a combustion of gases, there is more inhalation of the
yes. More chances of inhalation. And other than that, you should ask a few things regarding from the family members, especially like regarding the mental status of the patient. Yes, whether he or she is suffering from conditions like epilepsy, or there is a history of drug abuse, alcohol intake. Yeah, these are important things that should be inquired about. When do you suspect that the patient may be having inhalation injury?
So patient is having any respiratory difficulty and having any change in voice and
yes,
hoarseness of the voice, and if on examination any and neck and facial burns,
yes,
and any deep neck burns, and if on examination of the oral cavity, if there is any carbonaceous material or patient is coughing out any sputum and black sputum, I suspect the inhalation injury. So,
yes. And if you ask the patient to open the mouth, you find blisters, evidence of burn in the oral cavity. If you find that there is singeing of the hair in the nostril, yeah, these are the important points which points to, important things which points towards the possibility of an inhalation injury. Okay, now. What are the criteria for admitting a patient into a burn unit when the patient comes to you, as you said?
Any patient with having the total burn surface area more than 10% in adults or 15% in the children. Any full thickness burns.
Actually, Jyoti, this concept has been changed. I've gone to the recent things. Now people are saying that a burn of 20% is a criteria for admission. So the earlier concept of 10% is not there. unless patient has already associated inhalation injury. So it should be, the answer should be 20% burn.
Any full thickness burns, chemical, electrical, and inhalation injuries, and in extremes of age patients, and
not any full thickness.
Full thickness,
not any full thickness burn, but the extent. Yeah. So any burn which might require fluid resuscitation when you are suspecting an airway or inhalation injury. Yes, which burns which will require some form of surgical intervention, like tangential excision. Then, as you said rightly, burns involving the head, face and neck region, or burns especially involving the hands, feet, perineum. These are the areas where the patient should require immediate admission. If you are suspecting that the patient is having some psychiatric disorders, if you are suspecting some foul play regarding the circumstances of the injury, extremes of ages, and as you also said that special type of burns like high tension electrical injuries, or some chemical burns which may be of serious nature, those patients must be admitted. What are the like, for example, in your case scenario, what should be the things that should be managed or that should be done on the site, at the site of injuries, at the site of burn injury?
So first, patient has to take out of the burn place. She has to be protected from further exposure to the burn, and any clothing, as it is involving the fire burn, the clothing has to be removed because to avoid further injury, and patient and any rings and everything which jewelry has to be removed, and expose the patient, cooling the patient has a temperature, high temperature. Cooling the patient.
First of all, take out the clothes and stop the burning process itself. So that might require, wrapping the patient up in some, what you call blankets, and roll the patient on the ground so that the burning process stops. First of all, make sure that the person who is rescuing the patient is not injured in the process. That should be also ensured. Then, as you said, you have to cool the patient by.
How is this done? How is cooling done?
Yes, how is cooling done?
This is just rinsing with clean water. You should rinse the whole burn body with the clean water.
How long should you put the patient in the running water or clean water, as you say? How long?
30 minutes only, sir. Not more than that.
Yeah, max 10 to 15 minutes. How does it help basically?
So it prevents, as it's at high temperature, it prevents further temperature. It cools the body, so there is no, it won't change the full thickness. It won't convert the partial thickness.
Yes, it basically slows down the process of the microvascular damage that occurs because of the burn. Should you use if ice cold water is available? Should you use that?
No, sir. It causes hypothermia of the patient.
Very good. And neither should you ask the patient, if you have got a bathtub or something, do not immerse the entire body into the bathtub. It should be a running water in which you should wash. Then what should you do? You should cover the patient up in a clean cloth and transport the patient as soon as possible to a nearest hospital. Do not apply any of those locally available. Some people apply all those stuff that is available in their house, like toothpaste and all. So that should be absolutely avoided. Next, once the patient comes to the casualty, what are the how do you approach the patient in the casualty?
According to ATLS protocol, after my primary survey, I will proceed with secondary survey, sir. I'll ask the detailed history and I will do the head-to-toe examination, sir. And I will assess the burn surface area and the depth of burn.
What is the purpose of doing the secondary survey, basically?
To know the history and to know that any patient is having any medical illnesses and patients.
No, secondary survey.
Detailed head-to-toe.
Yeah. What is the idea? So you should. The idea is that you should not, miss injuries like spinal injury, head injury, which may be associated with burn injuries also. Okay, next you assess the
burn surface area.
Yeah, total body surface. Why is it so important to measure the total body surface area of the burn?
So it is associated with the how much burn is involved, how much that much inflammation is going to occur in the patient's body. So
very good, very good. So you assess the degree of inflammatory reaction that is directly proportional to the percentage of burn, and that will also help you in assessing how much of fluid that is required for resuscitation. Like for example, how much of what percentage of the burn may lead to shock? Above what percentage?
So about 20%.
20%. Yes, as I said, 20%. Right. And if the burn surface area is like, for example, other utility of knowing the burn, the percentage of burn is like, for example, if the burn surface area is more than 20%, 25%, there is a possibility of because of the extensive inflammatory reaction, there may be loss of fluid not only from the surface of the burn area, but also from areas remote to the burn. For example, the burn may be in the upper limb, but you will find this, the limbs of the lower limbs getting swelled up. The loss of fluid may be there in the perineal cavity, in the pleural cavity, in the alveolar bed, right? So that is all because of the extensive inflammation. Right. Next, what else? Surface area, as you said. So how do you assess the surface area? Yeah, surface area, how do you assess?
So according to the rule of 9.
Yes, that is one. Anything else?
And in any small ones, I mean, areas affecting smaller areas, hand rule can be used.
How do you do that? How do you do that?
The patient's open hand will assess the burn surface areas. Each per hand open is equal to 1%.
But you cannot keep moving the hand all over the area, na?
Paper, so paper is cut into the side.
Yes, yeah. Cut a piece of clean paper the size of a patient's whole hand, including the palms and the digits, and that represents approximately 1% of the total body surface area. But that is the catch here is that it should not be an extensive burn, small area burn. Any other formulas? I mean, things that are used?
Land and broader.
Broader. Where for whom it is applicable?
So children.
Yes, for children. Yes. So how does why this rule is different? Like, for example, can you tell us about the changes in the surface area of different parts of the body from, say, newborn to an adult, roughly? Like how the percentage of head neck region changes, say from
in adults 9%, but in children it is 18%, sir. But in lower age it is 18% in each. In adults, but it is children.
So it becomes half basically. The head neck area surface area at birth is double that of the head neck surface area in an adult or children over 15 years. Okay. Similarly, on the other hand, the surface area of the thigh will become double as the child grows up, say from say 0 years to around 15 years. Okay, so isn't it? That becomes double. The head neck area surface area will become half, the thigh area becomes double. That's all. Okay, next, what else? How do you assess the depth of the burn, as you said? Yeah.
So by seeing at the surface of the burn surface, we can assess the.
Tell us.
So
what are the different? How do you classify the depth of burns?
So it is first degree, second degree, or can be third degree or fourth degree burns. First degree involving the epidermis. So if patient is having only pain and erythema, there is no changes. I mean, no blisters, anything. Patient is having pain, sir. And second degree burns, it may be superficial or deep. In superficial things, blisters will be there. And if you remove and the area is pink and moist, there is pain will be there, and capillary feeling is also there. In deep ones, there may be altered sensation. Patient can't differentiate between superficial, sharp and deep pain, and capillary feeling will be delayed. And mottling will be there. Capillary due to and dry, pale and
dry.
Depth is what? Depth in the second degree is there is a deep to epidermis, there is dermis, and dermis has two layers. One is the papillary dermis and reticular dermis. So in superficial dermal burn, It is a papillary dermis which is involved. And in the next, deep dermal, variable amount of reticular dermis. That is the extent, depth of the burn. Yes. Third degree?
Third degree involvement of epidermis and dermis. So, in this patient is having a leathery appearance of the field, and this patient don't have any pain or any capillary filling. In fourth degree burns, patient burn may extend up to the tendons, bones, and muscles.
Very good. So next is, now you have assessed the patient's extent of burn, you have assessed the depth of the burn. Next important thing is to start the resuscitation. For that, you need to have a wide bore IV, access, some IV access. Especially where do you, what are the areas where you should try to start this line, the referral line?
Check for non-burnt area for IV access. If it is not there, even can we do in the if it's not there, venesection or central line patient can be.
Venesection should be avoided as far as possible. Okay, especially nowadays you have these central line. It is easy to get these central lines done. So central lines will be better. Why, isn't it? Instead of a peripheral line or a cut down. Cut down should be avoided as far as possible. A long line either in the subclavian or the external jugular vein is preferable. All right. Next. Next, you start the fluid resuscitation. How do you do that? You use some formulas. What are those?
Parkland formula I use, and it's 4 into total percentage of burn surface area into the weight of the body. We'll use in ml. It has to be replaced in first half of the fluid in first 8 hours, and next half.
Why is it so that you replace it in the first 8 hours? Half of the fluid should be replaced in first 8 hours.
The volume lost is inflammatory reaction compensating. It is maximum in the first 8.
Yes, the maximum amount of loss of fluid is in the first 8 hours. So it has to be replaced in the first 8. Half of it should be given in the first 8 hours. Next.
The
next half should in the
next 16 hours.
16 hours. Okay. All right. That is from how do you 16 hours or 8 hours, whatever you said, is calculated from the where from the point when the patient
burn, patient attending burns.
Patient time of attending the hospital.
Within 24 hours burn injuries.
This 8 hours calculation is from which time?
From burn occurs.
From the time of burn.
From the time of burn, right? From the time of. Okay. From the yes, this is for the first 24 hours. 8 hours divided into 8 hours and next 16 hours. Next, what about the next 24 hours?
So next
usually the fluid requirement will gradually reduce over next 24 and 30 to 48 hours, isn't it? So next 24 hours it will be.
Sir, we'll calculate the fluid according to the maintenance fluid plus evaporative losses from the surface area.
No, in the first 24 hours from the time of burn, the replacement should be, this is basically a replacement fluid. That should be 4 ml per kg per percentage of burn. Okay, next 24 hours, you bring down this amount to about 2 ml per kg per percentage of burn. Okay, but in children, sometimes over and above this replacement, you need to have a maintenance fluid as well. Okay, yeah. And what fluid would you suggest? Which particular fluid?
In children?
Crystalloid?
Adult.
No, in adults.
The Ringer's solution. Ringer's lactate.
Ringer's lactate. Okay. What is the role of hypertonic saline in IV fluid resuscitation?
Hypertonic saline.
Is there any role?
Can be. It can be have a role, sir, but because it increases the edema, and so it may lessen the further.
No. It reduces the edema, in fact. The hypertonic saline is proposed, is recommended by some people because it reduces the shift of the fluid to the extracellular space because of its hyperosmolar nature. And over and above that, one of the dangers of IV fluid resuscitation is overhydration and hyponatremia, which may be fatal sometimes. So that is avoided with this hypertonic saline. And hypertonic saline, by reducing this edema, also reduces the need for intubation and sometimes even escharotomies also. When do you require colloids, and what is the role of colloid?
So colloids initial 8 to 12 hours, there will be increased permeability even to proteins due to high inflammatory reaction. It's better to avoid colloids in the first 8 to 12 hours. After 24 hours, you can start colloids.
24 hours.
What will happen if the protein leaks out?
So
what is the problem? They give patient colloid and this leaks out of the capillary bed.
So maximum oncotic pressure proteins, if it gets leaked into interstitial, again there is further accumulation of fluid in
yes.
So it will make the condition worse.
This can cause pulmonary edema. This can aggravate the peripheral edema. So these colloids are not in the first 8 to 12 hours. How much sodium is there in hypertonic saline?
So 7.
How much sodium?
So usually
250 millimole sodium is there in the per liter in hypertonic saline. The advantage is this is also known as low volume resuscitation.
Yes. What is the formula that is used for colloid resuscitation?
Moore and Barkley.
Barkley. What is that?
So
0.5 ml.
0.5 ml per kg per body percentage area, plus 2% of colloids, plus 2% of free water. 2 liters of free water.
So that is divided into portions, isn't it?
Portions.
And you divide it into how? One portion should be given every.
For either
how is it?
12 by 12 or 4 by 4 by 4 or 6 by 6.
Yes. 4 by 4 by 4, 6 by 6, and 12 hours respectively. Very good. And now, while you are doing this fluid resuscitation, how should you monitor the amount of the resuscitative procedure as a whole?
The patient vital pulse, blood pressure, and the most accurate objective measurement is urine output. After catheterizing the patient, urine output is the best.
How much should be the urine output?
So it should be at least 0.5 to 1 ml per kg per hour.
Very good. In children, it should be a slightly higher rate, size. 1 to 2 ml per kg per hour. And if you find the urine output is not as per your requirement, it is a little bit low, what can you do over and above this this fluid, that is replacement fluid that you are given?
So we can increase the fluid.
You can. Yes. You can, yeah, very good. Bolus doses can be given around 10 ml per kg of body weight. You can give to see whether the urine output increases or not. Now, if you find that the urine output is more than 2 ml per kg, what do you suspect?
So patient is having overhydration or.
Very good. So in such cases, if you have a central line, the CVP monitoring will be of great help to avoid this overhydration and consequent hyponatremia. Any other methods of monitoring this process, entire thing?
If I put the question a different way, in view of high volume resuscitation and its side effects, a concept has come known as goal-directed fluid therapy. Goal-directed fluid. What do you mean by that? What is goal-directed fluid therapy? Yes. What else? So goal-directed fluid therapy does not rely on pulse and blood pressure. That relies on central venous pressure, pulmonary capillary waste pressure, and there is some device you can measure the cardiac index, stroke volume. So if you are giving some amount of fluid which is maintaining the stroke volume, that is adequate fluid you require. So that way you avoid overhydration. So now the concept has come, it should be not zero balance. That is different. There is another term called zero balance fluid therapy. That means whatever is output, you are replacing that. Goal-directed fluid therapy is you monitor the vitals like CBP, pulmonary capillary waste pressure, and cardiac index, and then replace the fluid based on the index. Yes.
Okay, just some passing questions. when do you want to purposefully keep the urine output above 2 ml per kg per hour?
Patient sustained any high voltage electrical injuries.
Very good, very good. Why should it be like that? Why should the output be more than 2?
High voltage electrical injury. Patient may have renal damage because of muscle damage. Myoglobins will be.
Very good, very good. So that should be flushed out as far as possible.
What else you add in the fluid in that case?
So sodium bicarbonate.
Yes. So
yes.
you have to alkalinize
because of the acidosis that occurs in such cases. And other means of monitoring parameters, maybe not applicable for you, this particular patient that you are describing, is an ECG for electrical burn, isn't it?
Yes.
Regular ECG because there is a possibility of cardiac damage and electrical burns. And in your case also, an regular ABG monitoring is required to see whether, because there is a possibility it was a closed room injury, so possibility of inhalation injuries are there. When do you intubate such patients? What are the indications?
The patient is having tachycardia and increasing respiratory rate, and patient is distressed, and patient having falling saturations.
Yes. So preferably the intubation should be done within
4 to 12 hours.
Yes, because the further delay, yes, severe edema will take place. Very good. Over and above these things, in the casualty, you must ensure that the medical legal formalities are completed, police information is done. This should be tetanus prophylaxis is given, isn't it? Okay. What are the next? Once the patient is shifted from the casualty to the burn ICU, how do you next monitor these patients? Over and above the things we had already discussed. Most of the things we have already discussed.
So patient has to.
So apart from fluid management, what are the
other things
ancillary treatment you provide at this stage?
So burn management.
Before burn, patient is severe pain.
Yes.
The next important is pain control.
Yes,
and next
very
is
important.
The burn is susceptible for wound infection. Although burn is sterile at the time of accident, there is subsequent chance of contamination. So the next point is to control the pain. What drug you use for this?
So opiates will.
Yes, opiate has got a very good analgesic effect, but while giving opiate, what should take care? You should take
respiratory repair.
Yes.
All right. Other than that, you should start the physiotherapy part, the chest physiotherapy, the physiotherapy of the extremities should be start as early as possible. I mean, from the second day, preferably from the second day onwards. You should monitor the hemoglobin, hematocrit, other electrolyte parameters, renal function parameters regularly on a daily basis, isn't it?
Yes.
Do the dressing of the wounds in the burn unit. What is the best what you call material available for dressing commonly?
Silver sulfadiazine.
Silver sulfadiazine. What are the contraindications for silver sulfadiazine? When shouldn't you use? Is there any contraindication? No. No, it should be avoided in
pregnancy.
Yeah, very good. So it should be avoided in pregnant women, nursing mothers, or even infants less than around 4 to 5 months of age, because of the possibility of kernicterus developing. Okay. Next, what should be?
Yes. How will you exclude compartment syndrome in burn wounds?
First one, pain is there.
This is a patient who has got flame burn. Somebody having fire in the kitchen means patients got flame burns, and flame burns are usually deep burns. So how you exclude that the patient is developing some compartment syndrome.
So patient is having severe pain out of proportion.
No. So deep burn patient is almost insensitive. Patient may have no pain at the burn site. Compartment syndrome is different in trunk and in the extremities. What happens in extremities?
So it will cause the edema of the distal part, and it further occludes the.
There will be signs of ischemia. There will be signs of ischemia in the toes and the fingers. So in circumferential burns of the limbs, you will find the limb is
swelling up,
and there is absence of capillary filling, or distal part of the toes may appear black because of ischemia. That is one in the extremities. What in the trunk?
Difficulty in.
Yes. If you have a subvalvular burn in the chest or in the abdomen, patient will have respiratory distress. And unless you do escharotomy, this will not get relieved. So they are the important thing they should do within 6 to 8 hours of the burn.
Now, what are the incisions that you use for escharotomy?
So in upper limbs it is mediaxial, anterior to the elbow to avoid the increased swellana. In the chest it is lateral to the nipples and along the clavicles and the sternum joint.
No. In the lateral.
Lateral to the
lateral. In the chest, you start in the mid-axillary line and go down on either side. Okay, it's in the left. And in the limbs, it is medial and lateral. In the limbs, it is medial incision. And how far depth this incision should be?
So it is the deep.
Full thickness.
Full thickness.
Means what?
Till the full.
Where do you stop?
Deep fascia.
You have to incise the deep fascia. So once you incise, you see that you are inside deep fascia because the most compression occurs deep to the deep fascia. So if you incise this burn wound, you have to ensure that you are inside the deep fascia also. That provides adequate release.
Very good. And what are the sources of infection in a patient when the patient is being treated in a burn unit? There is, as I already told you, that initially it is a sterile wound, but over a period of time, it can the patient may become septic. So what are the sources of infection?
As it burns surface, as there is a loss of epithelium, which is a barrier, is a direct infection will be there, and we are putting a catheter, a urinary catheter, and the central line axis, and any intubated.
So if you go by the source, one is patient endogenous. That means patient own flora may become pathogenic. The skin flora which are already burnt is sterile, but subsequently there may be flora in the endogenous, and in exogenous means in the environment. Patient in the burn ward, there is a lot of other patients, the environment, the dressings, okay, sprayed from the healthcare worker. So it is either endogenous, patient own flora, or exogenous.
How can the gut flora, as you said that the gut is maybe a source of infection, how can the gut flora be the source of infection in case of burns?
As there is, if there is, say it's an inflammatory reaction, there is decreased to the gut mucosa. So, and patient is also patient is not taking any food. There is mucosal atrophy and decreased permeability of the vascular leads to translocation of bacteria.
Very good. So what should be done to prevent this?
And early, it is a station and early enteral feeding has to be started.
Early enteral feeding. How do you do that?
So if patient by rice tube feeding.
Yes, if the patient cannot take orally, you should allow the patient. You should put it in a rice tube, nasogastric tube, and start the feeding. Preferably, you start the feeding within first 6 hours only. 6 hours after the injury to prevent the gut mucosal damage.
Any role for PPI in the initial management?
Yes. And there is stress, so patient may have hyperkalemia.
Patient with major burns may develop Curling's ulcers, which are stress ulcers. So one should use PPI or H2 blockers.
So these two are very important. One is analgesics and this PPI, H2 receptor blocker, PPI, whatever. These are very important as other than the other things that we have discussed now. What is the role of surgery in case of burns?
So
what are the indications? Yeah.
In case of circumferential burns in the upper limbs or in the torso, or in case of any deep burns, full thickness, deep dermal burns or in full thickness burns, we can go for the excision of the.
No, keep in mind, sir has asked you role of surgery. The first part of surgery is just sclerotomy, number one.
Sclerotomy we had already discussed.
Second,
yes.
Second is, what is the newer concept in burn management, burn wound management?
Early excision and.
So if you said it is a superficial burn, it is likely to heal. There is no question of surgery. If you suspect it's a deep dermal burn or burn of 3rd degree, it is unlikely to heal without scarring. And again, there is always a chance of infection. So what is the recent concept in burn management, wound management?
So early excision and grafting is the.
So that is the concept. But again, you have to keep in mind the
Wound
patient general conditions, the area of burn. Excision and wound grafting require a normal skin in the patient own body. So that is the concept now. You do early tangential excision and do the grafting. Yes. Now the question of.
So that.
Yes. Yes.
Yeah. So this tangential excision is important not only to prevent the secondary the consequences of deep burn, but it also brings down, as it's called, the burn load of the burn load, so that the inflammatory process as it is, that all the parameters, inflammatory parameters, will not come down unless and until you have removed the burn tissue totally. And for that, this is very important that you do a tangential excision of the burn, followed by some form of coverage, either temporary or temporary, like what may be given as a temporary cover.
So the biological synthetic dressings, whatever available.
Yeah, so that will bring down the burn load. The burn tissue is out. Cover it up with some temporary means, or you can, if this, as I said, if the skin is available, you can cover it up with a split thickness skin graft. But the point is that such excision carries a lot of possibility of blood loss, isn't it? So that should be kept in mind, that you are adequately prepared to the. I think we have covered most of the things.
Yes,
Professor
almost.
Shah, I think.
Almost. If I come to the, suppose we come to some basic questions otherwise, suppose this is a major accident involving a lot of people and there is a burn, maybe the home or terrorist activities, whatever. So you have a large number of burn victims. So what is the concept of triage in burn wounds?
So patient.
How do you triage burn patients?
So very severe patients, who are not able to survive the life can be given the least preference with less burn percentage, who can be saved with proper treatment and resuscitation, can be shifted early to the hospital.
You see, you have to shift everyone, but when you triage the patient, there is a concept called do not resuscitate or do not intubate. So these are the patients who are having a severe burn, more than 60% of burn, elderly patients who are unlikely to survive. Okay? Rather than the patient who has got lesser degree of burn, patient, a young patient who has a high chance of survival, they are the patient who should be early shifted to the burn center. But even with severe burn, that also patient should be taken care of. That means you have to triage the patient to the nearby hospital. And when you decide about criteria to shift to ICU or criteria to shift to a burn center, there comes the other points. In all patients, you cannot make a patient lying down and crying of pain and you decide he is not to be intubated, not to be decided. He is also to be relieved of his pain and anxiety. He should be on IV fluid. Okay, so this is burn triage, where there is a major accident. You have to sort the patient depending on the degree and depth of burn, depending on the other patient status, depending on the inertial injuries. All patients should be shifted to the nearby hospital. Whether this patient goes to their burn center, which is a specialized center, that is based on the criteria. But again, a patient who are thinking that is not able to be resuscitated, that also patient sometimes he expect that he gets the best care. So if the facility is there, he should shift him also. What can be done on the spot? We don't have a good pre-hospital care. So if a good pre-hospital care, what can be done on the spot?
So we can start with the cooling of the patient, and if there is no any limb.
These two are discussed. You take the burn patient off from the scene, cool, cover the patient with blanket. Apart from this, if you have a dedicated resuscitation team, what can be done for the burn patient at the time at the scene of accident?
Oxygen can be given. Sir.
Yes, first is if the patient is having an airway problem, you can try to maintain the airway. If patient has got a breathing problem, you can assist ventilation, looking at the pulse oximeter, and then on the spot you can start IV fluid. One of the important at the point of accident is start the patient IV fluid. That is very important burn patient, because you should start the patient on IV fluid as soon as possible, and then after IV fluid you should shift the patient. So these are the few things you can, and if you have a kid having a pain relieving substance, so you give that drug. Patient is having severe pain. Maybe that site of burn is not having pain, but patient has pain because of the adjacent areas. So relieve the pain by giving analgesics. So these are the few things. Okay. So you said there are different degrees of burn. When a burn occurs, what is the pathology? What happens to the burn area? Depending on the pathological nature, you can divide the burn area into different zones. What are the zones?
Zone of according to Jackson's zone of coagulation, zone of stasis, and zone of hyperemia.
Yeah. What is that?
What our main zone of coagulation is already necrodead tissue burned area.
That means because of the thermal damage, there is coagulated necrosis of the proteins. So these are the cells which are dead. So around the dead cells, there is an area of stasis because of local vasoconstriction. Because of local vasoconstriction, there is an area of stasis. This area of stasis is important, because this area of stasis, if you do timely resuscitation, this area of stasis will become normal. If you are not doing the resuscitation properly, resuscitation is delayed, patient has got a severe infection, this area of stasis undergo necrosis. So this superficial burn may convert to deep burns. The area of burn may increase. And zone of hyperemia is because of local inflammatory mediators, which causes vasodilation. So these are the pathological aspect of burn which happens. You said this flame burn is important. Why inhalation injury is important?
So inhalation injury, it enters into the lower airway tract, so it causes chemical.
There can be either a direct parenchymal burn, or there can be inhalation injuries. So the other problem. Have you heard of something called box score?
Yes.
What is that?
So patients, it assess the prognosis of the patient.
Yes.
Age, it includes age and total burn surface.
And modified, you add class 17. For if you suspect inhalation injury, you add 17. If the score is more than 140 or 150, that indicates a very severe burn injury, and probably these are the patients who are not going to survive. So these are modified box score, where you add the age plus percentage of burn surface area and class 17, taking into account the inhalation injury. If the score is more than 140, that indicates he is a very severe burn injury patient, unlikely to survive. Dr. Bhattacharya, any other question?
No, I think she has answered.
How
excellent.
Yes, she has answered well. Yes. How do you prevent burn contracture? Because that is one of the important sequelae of burn injury. This contraction can occur in the neck. This contraction occur in the limbs. So how will you prevent burn contraction?
So when it's prone areas has to be protected, and early splinting of the limbs and starting early physiotherapy of the.
It should address some other issues. When does this contraction occurs? This doesn't occur in first degree burn or superficial second degree burn. This burn contraction occurs when you have a deep burns which are not managed properly. Okay, so one concept to prevent this contracture is early tendon excision and skin grafting. And after this also, you have to splint the limb properly and do active physiotherapy. So if you are not treating the patient of deep burns with early grafting, then the other sides which are likely to have granulation tissue, healing, leading to scarring. And even if you do grafting in a patient who has got granulation tissue, unless you do active physiotherapy and proper splinting, the other patient likely to have burn contraction. So the idea is to prevent the burn contraction by taking good burn care. What are the different skin substitutes used in burn wound management? Skin substitutes.
Integra.
What are these actually?
So these are
biological dressings. These are biological dressings which contains maybe some stem cells like fetal fibroblasts taken from the umbilical cord. Okay, there may be some from human cadaver. For human cadaver, they are taking something called acellular dermal matrix. In human cadaver, they take the skin and do peeling of the epidermis. All the cells are taken off. This dermal matrix can be used as a dressing, which act as a scaffold. Once this wound starts granulating and this wound is clean, you can replace this by split grafting. When do you need to cover the wound with flaps? When do you need to cover the wound with a flap?
In full thickness in areas of the tendon, muscle, bone exposure.
Yes, in full thickness injury near the joints. Near the joints. If you have full thickness injury near the joints, if you apply on the split graft, that is not going to work well. Because either this will break down or there will be risk of contraction. In that case, you need to use local flaps or distant flaps.
Another complication, just the passing remark, another complication other than contracture is hypertrophic scars. So that can be a problem also. So that should be managed by, how do you prevent that rather, or treat that both?
Regular dressings and properly and pressure governments have the.
No, when the patient comes to you in the OPD during follow-up, you start examining the patient. You suspect that the patient might be developing a hypertrophic scar. From that point onwards, you should advise the patient to use some pressure guard. First and foremost, you should keep that area some moisturizing agents. Sometimes even you can ask them to apply coconut oil also. Coconut oil is a very good material to keep the area soft and supple. And over and above that, you advise these compression garment, as you said, and some interventions like local intraepidural injection of steroids and all that can be also given. And one thing that I think we overlooked is the psychological part of it. So that should also be kept in mind, that psychological counseling in burn patient is very important.
Yeah. Dr. Bosha, Dr. Bosha, any question?
The thing is covered nicely. One thing I want to think is that what is the role of antibiotic? Because initially the burn wound is sterile. So what antibiotic we use and when we use, and what is the role of culture, pus culture and fluid culture? Antibiotic someone kichu bolbe?
Yes, we have discussed.
We had already discussed.
Although burn wound is sterile at the time of accident, there is higher risk of this burn wound get contaminated by either endogenous bacteria or exogenous bacteria. So we are the patient who require prophylactic antibiotic.
Yes.
And that antibiotic should be basically, these are mostly at the staph infection.
Right.
So some anti-staph antibiotic should be given to prevent infection, but this antibiotic should not be continued for longer time. That will
Yes.
add to super infection. So if subsequently, okay, let me answer one question. How do you know patient has got a infection?
Yes.
What are the criteria to say patient is having infection in the burn wound?
Patient is patient is developing cellular.
Always there will be edema. How do you make out cellular? It's difficult. The point is patient will have fever, new onset fever. Patient may be toxic. Patient may be toxic. There may WBC count high and CRP being high. And the final is blood culture. So the prime indication for continuing antibiotic therapy is if the patient has a positive blood culture. Just having some surface growth and patient not having any evidence of invasive infection, antibiotic may not be required. Local antibiotic is good enough. Okay, but patient having a positive blood culture with high blood count, then in that case, you should give the patient antibiotics. Another question is whether it has been changed to 2%, 2 milliliter per, what is it? No, actually there are a lot of other formula coming up. If Parkland formula has been modified, some people claim that Parkland formula gives more fluid, but it has been observed that patient who has got inhalation injury, they require more fluid. So in that case, we'll find there are a lot of modifications of Parkland this Parkland formula. Some formula takes into 2 ml per kg per percent burn area, added up with colloid in the first 8 hours also. So there are a lot of modifications. You find there are 4 or 5 modifications of this Parkland formula. So the standard Parkland formula is 4 ml per kg per percent of burn area. But again, this is sometime in some patient is over, some patient is lower. So one has to balance. The concept now is to give the patient fluid based on the response to treatment. One regime say that you give the patient 1 liter per hour. You give the patient 1 liter per hour and keep on monitoring the patient. Once you find the urine output is coming to 1 ml per kg per hour, that means this patient is having adequate hydration. And subsequently you decide on the maintenance fluid. There is different formulas for calculating maintenance fluid. So it's not that you have to be based on the fixed formulas. Fixed formulas are not very pertinent in burn management at the moment. There are a lot of change. Okay, Dr. Bhattacharya, thank you so much.
Thank you very much.
Thank you.
Thank you.
Thank you.